So urticaria, erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis, they all can be triggered by drugs. The drugs that can trigger urticaria it include aspirin and opioids. And other triggering factors include stress, caffeine, and alcohol. While the drugs that can trigger erythema multiforme, though the most common cause of erythema multiforme is an infection due to herpes simplex virus. Similarly, bacterial infection with mycoplasma or streptococcus can also trigger erythema multiforme. Now, the drugs that can elicit erythema multiforme, it include penicillin is the most common or most important drug that you need to remember. So, penicillin can trigger erythema multiforme. It can trigger Stevens-Johnson syndrome. It can trigger toxic epidermal necrolysis. So this drug is common to all of them. Other drugs include carbamazepine, NSAIDs, oral contraceptive pills, etc. So the causes of erythema multiforme is infection with viruses or bacteria, or drugs such as penicillin, carbamazepine, NSAIDs, etc. The presenting feature of erythema multiforme is a target lesion or multiple target lesion that starts on the back of the hand and feet and then spread to the body. There are two types of erythema multiforme minor, in which there is only involvement of the skin, and erythema multiforme major, in which mucosa is also involved. So our first topic for today is Stevens-Johnson syndrome. Previously, Stevens-Johnson syndrome was considered a severe form of erythema multiforme, but now it is considered a separate entity. Stevens-Johnson syndrome and toxic epidermal necrolysis, they both are same. Only toxic epidermal necrolysis is a more severe form of Stevens-Johnson syndrome. So if there is, when will you say that it's a Stevens-Johnson syndrome? It is basically a mild form of toxic epidermal necrolysis with less than 10% of body surface area detachment. So if the skin detachment is less than 10% of body surface area, then we will call it as Stevens-Johnson syndrome. And if the skin involvement is more than 30% of the total body surface area, then we'll call it as toxic epidermal necrolysis. And if the skin detachment is between 10 to 30%, then we'll call it as overlapping Stevens-Johnson syndrome and toxic epidermal necrolysis. In short, Stevens-Johnson syndrome and toxic epidermal necrolysis, the clinical features of both of them are same. Only in Stevens-Johnson syndrome, less than 10% of the body surface area is involved, and in toxic epidermal necrolysis, more than 30% of the body surface area is involved. Now, how a patient of Stevens-Johnson syndrome will present to you. The main presentation will be skin detachment after some drug intake such as penicillin. And typically there will be prodromal symptoms as well, such as headache, malaise, arthralgia, and a plurulent productive cough with plurulent sputum. The rash will begin as macules, then they will develop into papules, then vesicles, then bulla, and then plaques, and then skin will start to detach from the surface. So the rash will start as a macule, which is a flat erythema, then papule, then vesicles, then bulla, and then these bullas will rupture and result in the detachment of the skin. You can see that in this diagram, target lesions, erythema multiform is shown. Erythema multiform has 3 zones of color: red, pink, and white. Normally, erythema multiform has 3 zones of color, while Stevens-Johnson syndrome, the erythema of Stevens-Johnson syndrome, it has only 2 zones of color. So this can be a differentiating point between erythema multiform and Stevens-Johnson syndrome. Stevens-Johnson syndrome, a patient with Stevens-Johnson syndrome is managed in intensive care units, and the management is same as that of the patient with extensive burns, because there is extensive detachment of the skin. So the patient with the Stevens-Johnson syndrome are treated as same uh, like patient with burns. So the mainstay of treatment is basically fluid replacement and electrolyte correction. Other than fluid replacement and electrolyte correction, corticosteroids, immunosuppressant drugs such as corticosteroids and cyclophosphomides can also be used. Now, difference between erythema multiform and Stevens-Johnson syndrome and toxic epidermal necrolysis. We know that erythema multiform can be triggered by infections such as viral infection, bacterial infection, and the cause of Stevens-Johnson syndrome is only drugs. The other difference that you need to remember to differentiate between these two is that erythema multiform, in erythema multiform, there are fever and constitutional symptoms are absent, while in Stevens-Johnson syndrome, fever, headache, and myalgia, they precede the development of the rash. Erythema multiform has typical target lesion with 3 zones of color, while Stevens-Johnson syndrome has atypical target lesion with 2 zones of color. So remember these 3 differences that will help you in differentiating in erythema multiform and Stevens-Johnson syndrome or toxic epidermal necrolysis. So toxic epidermal necrolysis is basically a more severe form of Stevens-Johnson syndrome. So all the signs and symptoms of Stevens-Johnson syndrome and toxic epidermal necrolysis is same. The only difference is that in toxic epidermal necrolysis, there will be more than 30% of the total body surface area will be involved. The drugs are almost same. That was for erythema multiform, such as penicillin, allopurinol, carbamazepine, NSAIDs, etc. So Stevens-Johnson syndrome, toxic epidermal necrolysis, and erythema multiform, they are triggered by the same drugs. As well as erythema multiform can also be triggered by infections such as herpes simplex, mycoplasma, and streptococcus. Management of TEN and SJS is same. That is supportive care in the form of supportive care in the intensive care unit in the form of IV fluids and electrolyte replacement, stop the precipitating factors, immunosuppression in the form of steroids and cyclophosphamide. Other than that, intravenous immunoglobulins has been shown to be effective and now is considered first line in the management of Stevens-Johnson syndrome and toxic epidermal necrolysis. So the management presentation of Stevens-Johnson syndrome and toxic epidermal necrolysis is same, and the management is also same. So we are done with urticaria, erythema multiform, Stevens-Johnson syndrome, and toxic epidermal necrolysis. All of them can be triggered by drugs. The drugs for erythema multiform, toxic epidermal necrolysis, and Stevens-Johnson syndrome are same: penicillin, allopurinol, NSAIDs, and carbamazepine, etc. Well, the drugs that can trigger urticaria, it include aspirin and opioids, as well as other risk factors such as overheating or stress, caffeine or alcohol can also trigger urticaria. So this was all about rash that develop after drug intake and how to differentiate between different type of rashes that a person can develop after a drug intake. I hope it's clear to everyone. Next topic is erythema nodosum.
Yeah.
Again,
Sorry, one
yes,
question. In toxic epidermal necrolysis, there will be a prodromal symptom, same like in Steven-Johnson syndrome, like headache,
yes,
malaise.
yes.
It will be the same,
They
yeah?
are they are both the same. Their features, presenting features, and their management is same. The only difference is the total body surface area that
Sir,
is involved.
right. Okay. Thank you.
So our next topic is erythema nodosum. Erythema nodosum, as you can see from its name, that it is erythema mean redness and nodosum mean nodule formation. So red nodules, formation of red nodules is known as erythema nodosum. It is basically due to inflammation of subcutaneous fat that red tender nodules are formed under the skin, and erythema nodosum is associated with different inflammatory conditions. The important ones are TB and sarcoidosis. They can lead to erythema nodosum, inflammatory bowel disease, Behcet disease. We have discussed Behcet disease in the in the rheumatology chapter, that someone with recurrent genital ulcer, recurrent oral ulcer, and anterior or posterior uveitis. So a fourth feature of Behcet disease is erythema nodosum. So TB, sarcoidosis, inflammatory bowel disease, malignancies, and even drugs such as penicillin and sulfonamide. So you can see that erythema multiforme, Steven-Johnson syndrome, TEN, and even erythema nodosum, it can be triggered by penicillins. So after intake of penicillin, if someone develops tender red nodule, then your diagnosis will be erythema nodosum. Similarly, other than drugs, there are some other conditions which are associated with erythema nodosum, and it includes TB, tuberculosis, sarcoidosis, inflammatory bowel disease, and Behcet disease. And these erythema nodosum or red tender nodules, they most commonly occur on the shins, as you can see in this diagram. Formation of multiple red nodules, tender nodules on the shins. You can see here and here on the upper limb as well, but they are more common in the lower limb or on the shins. Next topic is erythema of Igne. So again, we'll focus on the name and we'll know what is the disease. Erythema ab Igne. Erythema redness, ab Igne, ab due to Igne fire. It's a Latin word which means due to fire. So erythema ab Igne literally means redness due to fire. So the cause of erythema ab Igne is chronic exposure to infrared radiation or heat, so redness that develop as a result of exposure to or overexposure to heats and heat. In heat, there are infrared radiation which can lead to the development of erythema ab acne. Now, what are the features of erythema ab acne? Remember that the main feature of erythema ab acne is that, as you can see in this diagram, the appearance of erythema ab acne is just like a fish net. See the net-like pattern that is present in erythema ab acne. So basically, erythema ab acne is reticulated. Reticulated means like a net. Erythematous patches with hyperpigmentation and sometimes telangiectasia. So someone with a history of overexposure to infrared radiation and who present to you with reticulated erythematous patches, then your diagnosis will be erythema ab acne. And the treatment of erythema ab acne is to treat the etiology or to avoid the exposure to heat. Now, some rash that are associated with pregnancy.
This
Or
erythema,
skin dis
sorry, erythema ab acne, can it develop like some people they sit in front of the heater? Can it
yes,
develop? Is it the same?
uh, yes. This in the Plab exam, the question will be asked exactly like this. An
Mhm.
elderly woman, there will be history of sitting in front of the heater or sitting in front of the fire, like in kitchen. So
Yeah.
yes,
Okay.
this is how a typical question will be asked about erythema ab acne.
Okay.
Now, some skin disorders that are associated with pregnancy. The first one is polymorphic eruption of pregnancy, PEP, or pruritic urticarial papules and plaques of pregnancy, PUPP. So during pregnancy, if a female develops pruritic itchy urticaria like rash, a pruritic rash in her last trimester, and a primary gravida. So polymorphic eruption of pregnancy, it occurs in the last trimester. This is one hint for polymorphic eruption of pregnancy. It occurs in the first pregnancy. The female will usually be a primiparous. It spares the umbilicus. Umbilicus is not involved in this rash, and there are no blister formation. So remember these 4 points for polymorphic eruption of pregnancy. That is a pruritic rash that occurs in the last trimester of first pregnancy. So last trimester of first pregnancy with no involvement of umbilicus and no blister formation. If this is the case, then your diagnosis will be polymorphic eruption of pregnancy. But if there is a rash, a pruritic rash with blister formation, and that occurs in the first or second trimester of pregnancy, and the pregnancy is not first as well, then your diagnosis will be pemphigoid gestationitis. So remember these 4 differences between polymorphic eruption of pregnancy and pemphigoid gestationis. Pemphigoid
What's the
gestationis,
difference? What's the difference between uh, PUPP and the other one, polymorphic
PEP,
syrup?
they are same thing. They are the two names of one disease. Polymorphic eruption of pregnancy is also known as pruritic, urticarial, papules, and plaques of pregnancy.
Right.
So they are the name of the same disease.
Okay.
The different disease is pemphigoid gastationis.
Right.
So in pemphigoid gastationis, umbilicus is usually involved, and there is blister formation too. So pruritic rash without blister is PEP, and with blister it is pemphigoid gastationis. Pruritic rash with the involvement of umbilicus, pemphigoid gastationis. Without involvement of the umbilicus, PEP. Pruritic rash that occurs in the first pregnancy, PEP. Pruritic rash that occurs in the second, third, fourth, or even further pregnancies, then it is pemphigoid gastationis, because pemphigoid gastationis does not occur in the first pregnancy. PEP occurs in the last trimester of pregnancy, and pemphigoid gestation occurs in the first and second trimester of pregnancy. The management is PEP is a mild condition, so it usually resolves with emollients and mild potency topical steroids. And if the disease is severe, then oral steroids may be required. And pemphigoid gastationis, because there is formation of the blisters and umbilicus is also involved, so usually it is treated with oral steroids. So the treatment of both of them is same. So we are done with different types of erythema and how to differentiate between them. Now there's a short summary of types of erythema and the main diagnostic points. Erythema multiforme, redness in many shapes or many forms, erythema multiforme. Target lesions, multiple target lesions will be seen. You can see this is a target lesion, this is a target lesion. Three zones of color, red, white, and pink is usually present. So target lesion, multiple target lesion that start on the dorsum of the hand, very itchy and painful. Caused by herpes simplex, mycoplasma, and penicillin. Erythema nodusoum, tender erythematous nodules or tender red nodules, usually over the shins, caused by inflammatory conditions such as inflammatory bowel disease, sarcoidosis, TB, and even penicillin can cause erythema nodusoum. Now, erythema marginatum. So, can somebody tell me which condition is associated with erythema marginatum? We discussed it in rheumatology chapter.
Rheumatic fever.
Yes, that's right. Excellent. So, erythema marginatum, as its name indicates, erythema with distinct or prominent margins. It is usually present pink rings on the torso, on the trunk, and the inner surfaces of the limbs is known as erythema marginatum. Now, we discussed that in erythema multiforme, there will be multiple target lesions, while in erythema migrans or erythema chronicum migrans, so again, we'll focus on its name, erythema migrans. It's an erythema that migrates, or you can say it's an erythema that grows in size. So a slowly growing erythema with an appearance of a target lesion. You can see in this diagram, it is usually present in the Lyme disease. So a single target lesion or a single annular erythematous rash that slowly expands. So this point is important to make a diagnosis of erythema chronicum migrans. That is, this redness, it slowly expands and it is present in Lyme disease. Erythema infectiosum. Erythema infectiosum is caused due to an infection due to parvovirus B19. It has a it is a bright red rash that is usually present on both cheeks, giving the appearance of a slapped cheek. So that's why it is also known as slab cheek syndrome. Erythema of Igne, erythema due to fire, chronic exposure to infrared radiation, usually elderly who sits close to an open fire or electric space heater. So this was all about different types of erythemas and how to identify them. I hope it's clear to everyone. If there's any question, people can ask. So no questions.